Thank you, everyone. So I have the great pleasure today of presenting you with an introduction to melanoma. So what is melanoma? What is the evolution of melanoma? How do we diagnose it? And a little bit about treatment. But there will be other speakers after me who will talk a little bit more in detail about each of these. I have no financial disclosures. So melanoma, this is considered the most serious form of skin cancer. It's the 5th leading cancer in men and the 7th in women. The American Cancer Society estimates that in 2016, about 76,000 new melanomas will be diagnosed. 46,000 in men and 29,000 in women. And about 10,000 people are expected to die from melanoma. So it's a serious disease. Over the past 20 or so years, we can see that the incidence of melanoma in the US has risen. But given the new treatments that have come along on the horizon, the melanoma mortality has actually stayed about level. It is 20 times more common in whites than African Americans, and the lifetime risk for melanoma is about 2.5% for whites, 0.1% for African Americans, and 0.5% for Hispanics. And the risk increases as people age, and the average age is 63 years. And there are many risk factors for melanoma, but one of the big ones is sun exposure and tanning bed use, which some of the other speakers will go into later. And the evolution, so how do melanomas arise? And there is a evolutionary model that's been proposed. And this is from the New England Journal recently, that so we know that melanoma starts from a precursor. And so the cell that becomes abnormal is the melanocyte. And as you accumulate mutations in the melanocyte, then you get benign moles, you get these nevi. As they accumulate more mutations, they may become these things we call intermediate neoplasms or dysplastic nevi. And as they become even more atypical, they become melanomas, melanoma in situ. And as they advance from the skin, they become invasive melanomas, and eventually they spread to other parts of the body. And so we know from genomic analysis that as the lesion progresses from a nevus to melanoma, you accumulate more mutations, point mutations, as well as copy number alterations of certain oncogenes. But one strong point is that the mutation signature reveals that UV radiation is very strongly associated with the development of these first precursor lesions. And so recently there's a lot of research in identifying what these driver genes are that lead to melanoma and metastasis. And so as melanoma advances, you first have a primary melanoma on the skin, and this is in stage 1 or 2 disease. But as you get to stage 3, the melanoma reaches the surrounding tissue, the lymph nodes, and as you reach stage 4 disease, you can get detectable tumor in other parts of the body. But it's very important for especially melanoma patients to see their doctors regularly, because in stage 1 or 2 disease, you can see that even as there is only detectable tumor in that one site, you can have microscopic lesions that have gone to other areas. So it's very important for you to follow up with your dermatologist, with your oncologist, or if you have advanced disease, your oncologist, and so forth. So how do we detect melanoma? So the main way of detecting melanoma is by the skin self-exam. So, we recommend patients get monthly self-exams, and in a well-lit room in front of a full-length mirror. A handheld mirror can be used for hard-to-see locations, and it's important to examine all areas, including the palms and soles, the scalp, the ears, the nails, and back. And this is kind of a visual of how that is. And then we often tell patients about the ABCDE mnemonic, and this stands for A for asymmetry, in which one half of the mole does not match the other half. B for borders, if it has irregular borders, ragged, notch, or blurred edges, this is a little bit more concerning. C for color, if the color is not uniform and you can have different shades of black, brown, pink, red, white, and or blue. And D for diameter, if it's greater than 6 millimeters, which is the size of a pencil eraser. Or E for evolution or evolving, when the mole is changing in size, shape, and or color. So these are all kind of red flags for how to, at least for your self-exam, to identify moles that may be a little bit more concerning. And of course, you can turn to specialists who can help with the exam. So who are these specialists? Dermatologists, ophthalmologists, gynecologists, dentists, and hairdressers even, because they examine different parts of your body. Of course, a dermatologic exam will probably be one of the most important. So when you see a dermatologist, what kind of things can they do? So we can provide a general clinical exam. We can identify lesions as whether they're melanomas or whether they're benign nevi, whether they're seborrheic keratoses or other benign lesions. We can perform total body photography, in which we take different pictures of your body, and over time we can track these moles and see if they change. And then we also have a device called the dermatoscope, which allows us to see features that may be more suggestive of a melanoma. And so, we often get patients like this in our clinic who have many different moles on their back. So which one is a melanoma? So we use, dermoscopy, and there are many new devices nowadays with from many different companies, and we'll see, maybe one of these lesions, which has many different colors, have many, features such as we call blue-gray structures, white lines, pseudopods, and so forth. And this would be more suggestive of a melanoma. And in fact, this was an invasive melanoma. We may find melanoma in other parts in strange locations on the body, which including the soles. This is a melanoma on a sun-exposed area. You can see the other lentigines that are in the area. And a melanoma in a less sun-exposed area. So what happens when we detect a melanoma? Then we can excise it. We can send it to a derm surgeon or a surgeon. They cut it out. And then the dermatopathologist takes a look at it under the microscope. You can see the clinical picture, the dermoscopic histopathologic image. And these were all melanomas. And so what are the components of the melanoma workup? So the dermatopathologist could detect a tumor. It can measure the tumor, determine the Breslow depth and the Clark level, how far it's invaded. It can change how we manage the patient. There's a NCCN guideline that's published, that's updated regularly, that provides kind of management guidelines for what to do in these different situations. The surgeons will talk later about sentinel lymph node biopsy. And this is when you inject the dye into the tumor surrounding area and see where the dye goes, the lymph node that will change color. And then you would take the first lymph node that changes color, and you would take that lymph node out, and that is a sentinel lymph node, which identifies where the tumor most likely may metastasize to. You can perform imaging, such as a PET-CT in this case, in this patient who had a lot of tumor all over the body, and after treatment with one of the newer therapies, now has a pretty clean PET-CT. With some of the newer drugs that are on the market today for melanoma, one of them is specific to a particular mutation called BRAF, and some patients with advanced disease may undergo BRAF mutation testing. So finally, there are many new treatments, and it's actually this is a very exciting time for melanoma, because not only do we have traditional surgical treatments, but now we have targeted therapy, we have immunotherapies, we do have the traditional chemotherapies that we give patients, but the most exciting has been these treatments that have provided durable remissions for patients for many years even. And of course, there's also radiation therapy that could be provided for these patients.